Welcome back to our special crosscast series on IMID and obesity, shared across RhAPPcast, GHAPPcast, and Dermcast, the official podcasts of RhAPP, GHAPP, and SDPA. I'm Amanda Mixon, your host for today. I am the current president of RhAPP and a PA in rheumatology, and I'll be your moderator for today's episode titled The Hidden Costs, Obesity's Role in Suboptimal Outcomes and Healthcare Burden in IMIDs. This series follows a unique educational initiative presented live at the national conferences of RhAPP, GHAPP, MAP, and SDPA, where advanced practice providers from rheumatology, gastroenterology, metabolic health, and dermatology come together to tackle the critical, often overlooked intersection between obesity and immune-mediated inflammatory diseases. In our first episode, we explored the evidence and broad impacts of this comorbid epidemic. Today, we're going to dive deeper, examining the pathophysiologic process that links obesity to poor outcomes in IMID. We will discuss how obesity fuels systemic inflammation, interferes with treatment efficacy, and drives increased healthcare utilization, leading to a cycle of worsened disease and higher burden across every level. Joining me are three expert colleagues, each representing one of the organizations that hosted this year's boot camps. If you all would please introduce yourselves.
Hi, I'm Laura Bush. I'm a practicing derm PA in Fayetteville, Georgia, and a past president of the SDPA.
Hi, my name's Erin Darguzis. I'm a nurse practitioner that specializes in inflammatory bowel disease in Chicago, Illinois.
Hi, I'm Jennifer Hernandez-Parra. I'm a nurse practitioner practicing at the University of Miami in metabolic surgery and obesity medicine.
Wow, I cannot think of a better panel, and oftentimes I think to myself, what am I doing here? But I'm so excited to dive into this discussion and explore how we as APPs can better recognize and respond to the systemic consequences of obesity and IMID care. So let's go ahead and dive right in. The first couple questions I think are probably the most challenging. So Erin, I want you to start us off, please. Can you explain how obesity contributes to systemic inflammation and what we currently understand about the pathophysiologic overlap between obesity and IMID?
So the first thing we think about is when a person consumes calories. Why do we consume calories? We do that so we can have energy. We use it for exercise. We use it for digestion. So our body uses the energy that is needed. Of that excess amount of energy, about 65% of that will go to the adipose tissue. Now, for a person who's consuming extra calories, this is an excess amount of energy getting stored into that tissue as well. So we notice a buildup. In the adipose tissue are the adipocytes. Those are the fat cells. Within the fat cells, that's where the energy is stored. If in obesity, what we see is this hypertrophy or this ballooning effect of the adipocytes. When this ballooning effect occurs, we will see this infiltration of these pro-inflammatory cytokines, macrophages such as TNF-α, interleukin-6. And when they continue to swell, they could potentially die as well. When these cells die, we then have these excrement of cells start to enter the bloodstream, and then more macrophages are going to infiltrate, and this causes what we call low-grade inflammatory response.
Wow, you actually made that really easy for me to understand. So thank you for that. I think our listeners will also really appreciate that too. Laura, talk to me about the inflammatory mediators that help explain why obesity worsens disease activity in conditions like psoriasis in your world, psoriatic arthritis in my world, and of course, IBD in Erin's world.
Well, in obesity, we know that the adipose tissue is acting as an endocrine organ and it's releasing pro-inflammatory cytokines. And of those, TNF-α, which promotes keratinocyte proliferation and joint damage. We have IL-6, which is fueling the systemic inflammation. And there's that metabolic dysfunction. IL-17 is actually recruiting neutrophils and sometimes involved in more of the plaque formation and even pustular psoriasis. You throw this mix in and it fuels the whole disease process of psoriasis and psoriatic arthritis.
Erin?
And for patients with inflammatory bowel disease, we will see an increased production of TNF-alpha more specifically. So when we see this increase of TNF-alpha in obesity and with a concomitant inflammatory bowel disease, we do get this double dosing of an inflammatory response as well.
And Erin, how does that inflammation impact therapeutic response in your patients?
So for a patient with obesity, we get concerned about the therapies they're on, especially more specifically biologics. We get concerned about quick drug clearance. And so with quick drug clearance, we get lower drug levels, which means that the patient isn't at a therapeutic range and ultimately will be at higher risk of developing a flare-up more frequently throughout the year.
Laura, do you have anything else to add?
So we know that in psoriasis, patients who are obese have a more difficult time reaching that minimal disease activity level. We know that they have higher PASI scores and that they're just generally more difficult to treat. So even they may take higher doses of medicine, but the medicine still may not achieve that minimal disease activity.
Super interesting. So it's obviously obesity causes inflammation, and then they won't respond to the therapies that we're giving them to tackle their disease. So again, so important that we understand that concept, I think, so that we can have those discussions and really think about this as being just as important as talking to our patients about their biologics, right? Talking to them about obesity. Jennifer, how does the pharmacokinetic profile of certain therapies change in patients with obesity? And what should APPs keep in mind when managing medications in this population?
So, I mean, you have to realize that there are a lot of potential treatment options out there for obesity, but they can affect certain, disease conditions. You have to it's a really personalized type of treatment. A lot of patients come in asking, I have, a cousin who's on this medication, or I have, I know my neighbor is taking this and they've done so well. And every case is extremely different. The medications that are out there, they have their own specific FDA indications as well. That helps us get coverage for them, because getting coverage is a whole nother topic for a whole nother time. It's definitely a battle, but then you also have to take into consideration what their underlying conditions are. If they have IBD, or if they have psoriasis, or if they have another immune modulating type of disease process, you have to factor all that into when you're making a decision. So it's a little overwhelming sometimes.
I can imagine. I would not, want to do your specialty, but I'm so appreciative of your specialty. So we know that obesity leads to this more aggressive disease course. Laura, what does that actually look like for you in practice?
Well, I think obesity does make the disease much more challenging to treat. I have patients that have cycled through just about everything on the market and still looking for the next drug that gets them completely clear. We know that over 35 on BMI has a 6.5 times the risk of PSA. So we're always keeping that in the back of our mind too. It's going to affect their joints. So we know that the obesity is not only triggering the disease, but it's triggering psoriatic arthritis. And then the psoriatic arthritis is triggering more obesity. So it's kind of this vicious cycle.
Yeah, absolutely. Erin, what do you see in your clinic?
Yeah, and to piggyback on what Laura said about the medications, and what we mentioned before is when these patients are obese and we clear drugs quicker, they get sick more often. And so with more presence of inflammation, the acute inflammation turns to chronic inflammation. That's a big problem for patients with inflammatory bowel disease, and more specifically Crohn's disease, because this chronic inflammation over time can develop into stricturing or fibrotic disease. That fibrotic disease is irreversible. It is not treated with medicines, and ultimately requires surgery. So now we're introducing the idea of surgeries in these patients, and ultimately we don't want to see these patients in the hospital, because there comes with post-hospitalization, post-surgical risk in the obese patient.
I'm going to sound like a broken record, but we see that in rheumatology as well. I mean, again, not only talking about what the impact of being overweight is on their joints, but the lack of disease control that we deal with as well. And, you'll cycle through all these therapies and they're still not getting better. Their CRP is still high. They still have several swollen joints. And so it's the same story with all of these things. Now, Jennifer, what are the misconceptions among clinicians regarding how obesity affects IMID outcomes that you think need to be addressed more openly in the clinical setting?
I think it's working on a comfort level of just making these discussions. Because again, it's always been this kind of like yucky type topic that people really don't want to have to address because it opens up another plethora or can of worms. I think back in the day when we only really had surgery to help treat obesity, it was definitely a lot harder conversation to have. And providers do have misconceptions that all obese people they're lazy and they don't want to do. It's maybe that, I have a lot of patients who they run marathons, they exercise, they're just, there's something else going on that's contributing towards it. It's not just because, they're lazy and they overeat. There's a lot of misconceptions out there. And I think people are more open to it now than they were before. And I think more conversations are being had. But again, and the patient also needs to be ready to have that conversation too. And, how are you going to gauge that? I could tell you from personal experience, I was going down really, really quickly. My BMI was 35. I had a lot of my comorbidities were just going through the roof. And my primary sat me down. He's like, "You're in this space every single day. What are you doing?" And I'm like, "I'm fine. I'm fine. He's like, "You need to really seriously sit down and let's have a conversation about this." And then I had that aha moment, like, okay, but it took me getting to that point for him to feel comfortable bringing it up with me. I'm like, "You should have been having this conversation with me, months and years ago, probably, to avoid getting to this point."
Well, too, it's so important to build that trust, right? Like it was that aha moment that you had with your primary care. And obviously that's oftentimes where it starts. But I think we are also in this kind of unique opportunity because we often see these patients more than their primary care. There's been so many times where patients have said, "But you're my primary care." And I'm absolutely not your primary care. Like, I'm not doing that. You don't want me to try to do that.
That's right.
That would not go well.
No.
And so I think it leaves us with this very unique opportunity, to your point. Like those conversations should have been had years ago. But it's hard. It's hard to have those discussions. I know I struggle sometimes having that discussion with patients and actually, bridging the subject. And I think I have found after doing this for a lot of years, a way to talk to patients where it doesn't seem quite as intimidating or accusatory. I really put it to, look, this is your genetics. This is also your disease. And one makes the other one worse, et cetera, to try to take away some of that stigma, to have the conversation earlier. And I think that given we do have, new therapies, I think it has made it a little bit easier because they're everywhere and everybody, is interested in them.
I think we're getting better. I could tell you, again, from experience, the majority of my referrals come through my APP colleagues that I'm seeing. I'm not getting, I do get referrals from, physicians, but the majority of my referrals are, my APP primary doctor is concerned about my weight and this is why she referred me to you. My GI APP is concerned about this and this is why they referred me over, which I think is great. I think it's fantastic.
I think APPs have a very unique and special ability to be able to talk to patients and collaborate with other specialties. And on that same note, I want to ask this question of everybody. What message would you give to fellow APPs in your specialty about recognizing the hidden burden of obesity in IMID care and its relevance to everyday treatment planning? Laura, I'm going to start with you.
I think letting them know that the systemic inflammation, as we learn more about the inflammation associated with obesity and the diseases we deal with, and that this is a recognized disease by medical associations that needs treatment and collaborative care. So the more we learn and we spread to our patients that we can't continue to ignore it, it's part of the treatment. It's part of the treatment of these IMIDs, right? So that's what I would spread the word on that. And then if you don't want to prescribe it, you refer. That is very easy to find a colleague in obesity medicine that you can send to because we know we can't often do everything in one visit, right?
Absolutely. Erin, what about you?
Well, I think it's easy for us to hone in on the burden of the autoimmune condition we're treating and how to improve the quality of life for the condition we're treating. And acknowledging obesity as this additional burden to their quality of life is really doing a disservice to them, because as we know over time, there are several risk factors that come into play with obesity, whether it's an autoimmune condition that they have concomitantly, a cardiovascular risk, an endocrine risk. If we're not addressing it, then we're not fully taking care of our patients. So it has to be a part of our discussion, whether I'm in GI, whether they're in derm, it has to be part of the discussion more regularly.
Absolutely. And I would echo all of that. I think to my rheumatology APP colleagues, I would say we need to bring it up. We don't have to necessarily manage it, although I think at some point everyone in this room will be managing it, but refer, have the early conversations, find somebody like Jennifer in your local community that can help you have these discussions. But we have to start it early. We have to understand that it is as big of a contributor to the inflammatory process as everything else is.
Also, as well, like this type of platform where we're amongst our own colleagues and, across the border, between the different groups and stuff like that, is have more of these boot camps and have more of these, podcasts and just more information and education available just to make us better.
Absolutely. I could not agree more. And I think that that's what makes these organizations so special, these APP-driven organizations where APPs are talking to other APPs. I think it truly changes how not only we manage our patients, but also even how we, treat ourselves, right? Because you can talk to other people that are in your specialty that are doing it day in and day out and have the same struggles as you do. So with that wraps up this episode of The Hidden Costs, Obesity's Role in Suboptimal Outcomes and Healthcare Burdens in IMIDs. A big thank you to our panelists for shedding light on the inflammatory mechanisms. Again, I would not have been able to do that, so thank you to Erin and Laura for doing that for me. I really, really appreciate it. It's so important, but also discussing the treatment challenges, Jennifer, I really appreciate that, and resource implications that make obesity such a critical factor in IMID care. If you found today's discussion valuable, don't miss the rest of the series, coming soon to RhAPPcast, GHAPPcast, and Dermcast. Be sure to follow at least one of these platforms, or all three, to stay up to date. You can also access every episode through the RhAPP ACE 2.0 and GHAPP ACE 2.0 mobile apps for convenient on-the-go learning. And stay tuned, our next episode is all about action. So we're going to move towards practice and dive into the practical strategies that APPs can use to improve outcomes for patients living with obesity and IMIDs. Thanks for joining us. Till next time.